Hello everyone, I'm Anas Al Ubaidi, and the title or the topic for this session is Final Assessment Endocrinology and Rheumatology Scribe Certification Exam within Chapter 31 of Review of Endocrinology and Rheumatology Scribing within the Certified Medical Administrative Assistant course program by ACMSO. Introduction. The final assessment for the Endocrinology and Rheumatology Scribe Certification Exam stands as a critical milestone for aspiring medical scribes specializing in these challenging and interconnected fields. Endocrinology and rheumatology center around some of the most intricate systems of the human body, the hormonal and immune systems, which are crucial for maintaining balance and overall health. The role of a scribe in these specialties extends far beyond basic documentation. It involves the meticulous recording of complex conditions, diagnostic patterns, and treatment protocols while flagging critical information that could impact patient outcomes. Endocrinology covers diseases involving glands that regulate hormones such as DM, diabetes mellitus, thyroid dysfunctions, adrenal disorders, and bone health issues like osteoporosis. Accurate documentation in this area requires a deep understanding of hormonal regulation, laboratory markers, and symptom presentations. For instance, documenting the subtle signs of adrenal insufficiency or recognizing early indicators of diabetic complications like retinopathy demonstrates advanced knowledge and precision. Rheumatology, on the other hand, focuses on autoimmune and inflammatory conditions affecting joints, muscles, and connective tissues. This includes systemic illnesses like rheumatoid arthritis, RA, psoriatic arthritis, and systemic lupus erythematosus, SLE. Autoimmune disorders are complex and often require an interdisciplinary approach to treatment and management. Documenting detailed patient complaints from morning stiffness in RA rheumatoid arthritis to photosensitive rashes in SLE ensures that providers are able to craft accurate diagnoses and effective treatment plans. This exam evaluates not only technical knowledge of these conditions but also scribes' ability to communicate patient histories, diagnostic test results, and treatment strategies clearly and efficiently. Now, proficiency here means integrating clinical findings such as lab values, imaging reports, and symptom patterns into thoughtfully prepared documentation. This enhances the quality of patient care by allowing providers to focus on clinical decisions without worrying about missing important information. Key points: endocrinology documentation essentials. Now, key endocrine disorders and their presentation, understanding how to document common endocrine conditions is vital. The most frequently encountered disorders include type 2 diabetes, mellitus DM, capture symptoms such as polydipsia, polyuria, and intentional weight loss. Note critical lab values like HbA1c percentages and fasting glucose readings. For example, document HbA1c elevated to 8.2%, patient with 3-month history of frequent urination. Hypothyroidism, symptoms like fatigue, weight gain, bradycardia, and cold intolerance should be carefully noted. Correspond with lab findings like elevated TSH and decreased free T4 levels. Hyperthyroidism records symptoms such as palpitations, tremors, and heat intolerance, ensuring you include lab diagnostics showing suppressed TSH and elevated T3 levels. Adrenal disorders like Addison's disease, adrenal insufficiency often require the documentation of nonspecific symptoms like fatigue, low blood pressure, and electrolyte imbalances. For example, Na130, sodium 130, and K potassium 5.6. And here is a diagram showing the key endocrine disorders. Essential endocrinological lab testing. Key lab tests must be documented accurately, including interpretations where applicable. HbA1c and glucose monitoring record diagnostic or follow-up values. For example, HbA1c 7.5% despite adherence to insulin regimen, TSH, free T4, and free T3 specify details and trends to guide therapy adjustments for thyroid dysfunction. Cortisol levels, not abnormal serum levels, in suspected adrenal conditions. Conduct ACTH stimulation test if applicable. PTH and calcium, frequently associated with parathyroid issues. Documentation should capture hypercalcemia and hyperparathyroidism. Treatment pathways and adjustments for treatment documentation. Diabetes management include target ranges, insulin types and doses, oral hypoglycemics, dietary changes, and patient adherence issues. Thyroid hormone replacement. Document treatment like levothyroxine initiated at 25 mcg. Daily TSH goal between zero point 0.5 to 2.5 ml unit or MIUI per L. Bolstering bone health. Capture bisphosphonate treatments for calcium and vitamin D supplementation aims in osteoporosis uh, patients. Red flags in endocrine documentation. Recognizing critical signs and ensures timely intervention. Severe hypoglycemia, confusion, sweating, and reduced consciousness. Thyroid storm, tachycardia, hyperthyroidism, altered mental state, acute adrenal crisis, hypotension, vomiting, and shock, all life-threatening. Documenting these circumstances effectively can hasten uh, life-saving interventions. And here is a diagram recognizing red flags for urgent care. Rheumatology documentation essentials. Common rheumatological conditions. Rheumatology encompasses a wide range of conditions that scribes must document with precision. RA rheumatoid arthritis, not symmetric joint swelling, warmth, and morning stiffness lasting longer than an hour. Document inflammatory markers like elevated ESR. Systemic lupus erythematosus, SLE, record multi-system presentations such as malar rash, oral ulcers, and fatigue. ANA positively in a crucial aspect to document alongside disease activity scores. Gout include findings such as abrupt onset of joint pain, redness, often in the great toe, podagra. Uric acid levels provide diagnostic clarity. Lab tests and biomarkers in rheumatology. Effective scribing includes test results that support diagnoses. ANA and RF levels confirm autoimmune activity, record titers and patterns for differentiation. ESR and CRP increased values signify systemic inflammation. Trend analysis is key. Anti-dsDNA and anti-SM, lupus-specific markers that correlate with disease activity. Uric acid testing, elevated in most gout cases. Document serial levels if available. Types of imaging and their documentation. Imaging often supports rheumatological diagnoses, include findings from X-rays and MRIs, capture joint erosions or deformities as in RA rheumatoid arthritis. DIXA or DXA scans record bone density results in osteoporosis management. For example, document X-ray demonstrates periarticular demineralization and joint space narrowing. Treatment approaches. Rheumatological treatments vary widely. Comprehensive documentation should include the MARDS, which is disease-modifying anti-rheumatic drugs, include methotrexate dosing and follow-up lab monitoring. Biologics note medication schedules like adalimumab biweekly injections, capture patient response or adverse events. NSAIDs, non-steroidal inflammatory drugs, and corticosteroids record both systematic relief and long-term side effects. Flare-ups and emergency symptoms. Key red flags for rheumatological emergencies include severe RA rheumatoid arthritis flare causing acute immobility, SLE systemic lupus erythematosus with a nephropathy example, elevated creatinine proteinuria, septic arthritis requiring joint aspiration. Summary tables. Here we have table on common symptoms and their documentation, table on key diagnostic tests in endocrinology and rheumatology, table on endocrinology and rheumatology treatment modalities, table on red flags and critical symptoms and documentation, table on monitoring parameters for chronic conditions, and next, We will revise what we have covered via this lecture through some MCQs or multiple choice questions. Question 1. Which of the following symptoms is characteristic of rheumatoid arthritis and needs careful documentation? A. Unilateral joint pain without swelling. B. Symmetric joint stiffness lasting over an hour in the morning. C. Skin rash with no joint involvement. Or D. Heat intolerance and tremors. Definitely it's B, as rheumatoid arthritis typically presents with symmetrical joint stiffness, particularly in the morning, lasting over an hour. This differentiates it from other conditions like osteoarthritis OA, where stiffness usually improves quickly. Options A, C, and D are unrelated or indicate other conditions. Question 2. What is the most appropriate use of ANA testing in rheumatology cases? A. To confirm diagnosis of diabetes mellitus. B. To measure thyroid function in hyperthyroidism. C. To screen for systemic and autoimmune diseases like lupus. Or D. To monitor glucose control over a 3-month period. Definitely the answer is B, to screen for systemic autoimmune diseases like systemic lupus erythematosus, SLE. Now, ANA, anti-nuclear antibody testing, is a key screening tool for systemic autoimmune conditions such as lupus or rheumatoid arthritis, RA. It doesn't measure thyroid function, assess glucose control, or relate directly to diabetes. Question 3. Which laboratory value is diagnostic of poorly controlled diabetes? A. HbA1c of 8.5%, B. TSH of 0.3 MIU per L, ESR of 50 mm per hour, C, or D. Uric acid of 7.5 mg per dl. Definitely it's A. We are talking about diabetes. So an HbA1c level over 6.5% is diagnostic for diabetes. While a level of 8.5% indicates poorly glycemic control, TSH levels pertain to thyroid function. ESR is an inflammatory marker, and uric acid is related to gout. Question 4. When documenting an acute adrenal crisis, which findings are most critical to include? A. Hyperglycemia with mild joint pain. B. Hypotension, vomiting, and dehydration. C. Fever, symmetric joint swelling. Or D. Sweating and tremors after missing a meal. Definitely it's B for adrenal crisis. Hypotension, low blood pressures, vomiting, and dehydration. As acute adrenal crisis is a life-threatening condition requiring immediate documentation of symptoms such as hypotension, vomiting, and/or dehydration for proper management. Other options do not reflect the clinical presentation of adrenal crisis. Question 5. Why is documenting TSH levels crucial for patients receiving levothyroxine? A. To track inflammatory markers. B. To confirm remission of autoimmune diseases. C. To monitor thyroid function and treatment efficacy. Or D. To predict glucose variability. Definitely the answer is C, to monitor thyroid function and treatment efficacy. As TSH levels are essential for evaluating whether levothyroxine dosage is correcting hypothyroidism, monitoring ensures that treatment goals are achieved and adjustments are made as needed. Other options do not pertain to thyroid management. And here we come to the end of this lecture. Thank you very much and goodbye.